It makes you realize what all your efforts that you go through at school. It makes it like the realization that this is going to make a difference in the world.
Hello everyone, welcome to the latest episode of The Current, Touro University California's alumni podcast. We are coming to you live from the Social Justice Resource Center in the library here on campus. Joining us today is Dr. Jennifer Himmel. She's a DO graduate from the class of 2002. For those of you who are not familiar with the history of the campus, that's the second graduating class of the COM here. You're an emergency medical physician in the Tidewater area in Virginia. And also the president of the Alumni Association Board of Directors. So
that's the gig.
Thank you for coming all the way across country just to sit with us here in the library.
Well, that wasn't the only reason I came, but yes, I don't mind sitting in libraries. I spent a lot of time here as a student.
So that's a little bit of a joke. Dr. Himmel came across country to take part in our Mosaic Gala that happened just last night here on campus to support the Mosaic Scholarship Fund, our diversity scholarship fund for students here on campus. So thank you very much for traveling across country.
Oh, happy to.
We just couldn't have you here without doing a podcast.
Right, without talking. No, but we had talked about that before.
Yeah,
it was time to do. It's more fun to do it in person.
Yeah, so
everything's more fun in person.
Yeah, let's jump right in. Tell us what led you to a career as an osteopathic physician.
Well, failure as a physical therapist, I guess, would be what I would have to honestly say. But I thought I wanted to do physical therapy. My roommates in college were physical therapy students, and at our college you had to do volunteer work. I got to the 38th hour of 40 with Walter Brown, MSPT, in Niagara Falls, New York, and he looked at me one day and said, "What else are you thinking about?" And I said, "Huh?" And I thought it was his very polite way of saying, "You're really not very good at this, young lady." It wasn't. He said, "I feel like this isn't enough for you. What else are you thinking about?" And I said, "Medicine." He said, "What's holding you back?" And I said, "Well, there's this little class called organic chemistry. Have you heard of it?" And he's like, "Yes, I have." And I thankfully didn't have to take it. And he said, "But why don't you just take it? Why don't you just take it and see what happens?" And so I did. So here I am. Wow. Yeah, there was a completely mental stumbling block that I didn't want to take organic chemistry because all the people that I knew that had taken it just takes over your life. It's kind of like medicine, kind of takes over your life for a while, but organic chemistry really takes over your life. And so that's how I got here.
Okay.
That's how it started.
So you jumped that hurdle.
I did.
And what led you to Touro? I mean, second graduating class. There wasn't a lot going on here.
Yeah.
And you started in the San Francisco campus, correct?
Yeah. I did start in the San Francisco campus, and we were sharing space with the California Podiatry College, and we had a really good time while we were there. But the absolute honest answer is, and anyone who applies to medical school will tell you, they let me in on the first try. Touro let me in on the first try. Nova Southeastern had waitlisted me. I didn't have, my joke about applying to medical school was all you need is $3,500 and a dream. And that was when I was applying. I can't imagine how costly it is now. But you know, the taking the MCAT prep test or prep classes, sending off your application, doing the secondary applications, flying for an interview, getting a suit for an interview, like all of it total probably cost me about $3,600. And so you really have to decide whether or not you're going to take a chance or you're going to wait and take that chance, because that's a whole different chance. And I'm from California. I'm a military brat, but I was born at Port Hueneme Naval Hospital in Ventura County, California, and I had been living in Buffalo, New York for 9 years, and I was tired of winter, and Touro said, "Yes, we'll take you."
And here you are.
And here I am.
And then for a year or two, you made the move from San Francisco to Mare Island, right?
Yeah, that was, I didn't mind moving out of San Francisco. San Francisco was a much bigger city than I had ever lived in my life. And I sometimes found it overwhelming, and I sometimes found it really kind of lonely. Because even though I'm from California and I have family here, they're 100 miles from here. They're not actually, they weren't in the city. And so, and it's really, as a student, cost prohibitive. I used to buy 2 burritos on Friday afternoon, the big ones. They were like this, and they were $5, and I would cut them in half, and they would be my dinners as I sat in my chair in my apartment and studied, because it's just, it's too expensive. It's really a great town. It's a great town if you can enjoy it, but it was just too expensive.
Okay. So why don't you talk to us a little bit and tell us how Turo prepared you to start you along your career path?
Oh, well, that's the easy answer to that is that I'm not afraid to start a conversation with people. I'm not afraid to try something new. I'm not afraid to go out into the world and give it my best effort and forge my own path. I'm not afraid to do that.
Okay.
And you kind of need that in my line of work.
Well, that's true. Emergency medicine.
In my line of work. Yeah.
How about some fond memories from your time here?
Oh gosh, there's so many. I showed you the yearbook.
You did.
So I made a scrapbook of my own individual stuff. Though it's actually like it's too big to bring with me to show you. And if you hadn't lived it, I guess it wouldn't be terribly meaningful. But it's all of the fond memories that I have are of my classmates. But the one that I still tell people is about one of my classmates, Hassan, who we were standing when we were still in San Francisco. We were standing in a bar after classes got out. We had walked up the street to check out a bar because that's what you did on Fridays. And he's staring at the screen, and it's football. And he looks at me and he says, Jen, I think I finally have this figured out. This football thing figured out. You get 4 tries to go 10 yards. And I looked at him like, what? Like how? Yeah. Yeah. Like that's just, yeah. So it turns out he's from Egypt.
Oh, okay.
Yeah. And so they don't play American football
It's
in
football,
Egypt.
football.
It's
Right.
football, if it's anything, or it's rugby of some sort. And so it's not a national pastime that he would have enjoyed, but he was embracing it and trying to figure it out. And I just kind of laughed. And so then once we moved here and then went out on rotations, I asked him where he was going first, and he's like, "Oh, well, I'm taking some time off," or something like that. And I was like, "What are you doing?" And he's like, "Well, I have to go home." And so, little question here, little question there. So it turns out that his family is the ruling family in a particular region of Egypt, and he had to go back to ceremonially take over for his father. So it was, in effect, a coronation celebration of sorts. That he had to go home, and it was 3 months long. And so then he was going to come back and start his rotations. I'm like, that makes sense. Let's go home and put the crown on the head, and then I'm going to take it off, and I'm going to go back to the States, and I'm going to get my osteopathic medicine degree.
Yeah.
I mean, he was the nicest guy. I remember when we had a Dr. Evans from microbiology here, and he used to give these fantastic reviews of all the material and tell you basically like this is what's important out of what I have taught you. This is what you need to know going forward. And that was the material that was always on the test. I had another life, and I was really like a fast typist, and so I would just basically transcript his test. And Hassan went to see a family member someplace else for some reason, and he forgot to take his notes. But my email that's all he had to study, so that's what he studied, and he aced it. So Hassan and I are, we were good buddies. He just came up afterwards, and he's like, I got an A. And I was like, that doesn't surprise me. And he's like, no, you don't understand. I did it. I only got an A because I had your notes. We got a big hug.
Yeah, well,
He's real sweet. We were pretty close. Our class was pretty close.
I mean, I've seen that in my brief time, about a year and a half here on campus, that
Oh, yeah. Yeah.
the different cohorts just,
Mm-hmm.
you're
click,
with your people.
You click and you're with your people, yeah.
And one of the nice things here is that the university, I don't know if they did it, well, you were the only program here at the time, but now there's a fair amount of interdisciplinary activities that occur.
Oh, that's cool. That's really cool.
That are bringing the different programs together in a teaching and learning and serving the community kind of environment.
That's
that
awesome.
Maybe wasn't here when you were
No,
here.
but we were it.
Yeah.
We were it. The 75 of us were it.
Yeah.
And then there was the classes that were behind us, but we were up in Farragut, and that's where all of our lectures were, and the first years who were doing most of their biochemistry and stuff like that were in the classrooms that were down here in Lander Hall. And so we didn't really, on a day-to-day basis, see much of them unless there was a common break time.
Gotcha.
So, yeah.
All right. So tell us what you're doing now professionally, and kind of walk us through your career arc. Obviously you went on rotations, and then you came back and you graduated, and then you went off for residency. So why don't you pick up from when you left, when you crossed the stage?
When I crossed the stage on May 17th, 2002. I never forget that because I also graduated from college on May 17th.
Okay.
For some reason. I don't know why I remember that. So I took when I crossed the stage here, I had been fortunate enough to set up my rotations, and I recommend that everybody do this if you can, such that but we had a lot more leeway because we were, as long as you met your requirements, you could kind of do what you wanted with your schedule. So I had scheduled it such that I didn't take any vacations during what I felt was gun time, and so I had a month at the end of the year in April and into May where I didn't have a rotation, and so I went to Europe with a fellow student. And we didn't backpack around Europe, but we went to Europe, and so I had come back fresh and sunned and rested, and then we walk across the stage, and I said goodbye to my family here, and I drove cross country to Michigan to take my traditional rotating internship spot at Genesis Regional Medical Center in Flint. No, it's in Grand Blanc. Technically, it's south of Flint. And so, and then they had changed it just a little bit. There's tracking spots that encompass a traditional rotating internship, and they transition you into your program, and you don't have to reapply. I don't know if they still do that, if it's new, whatever. So some people do a traditional rotating internship, and then they have to reapply, like ophthalmology and dermatology. That's usually how that goes. And so, but mine was tracking, and so I didn't have to reapply, so I did all 4 years. And I feel like I needed all 4 years. Like I needed that time. To let it sink in, to see it, and you really learn so much more from your patients than you can ever possibly learn from a book. So that's what's really nice about seeing the Truett Hall and all of the ways that you enhance the learning to make it more hands-on, because really once you see a patient and you get their diagnosis and you go back and you read about it, like that's when it stays. That's when the knowledge stays. And so, anyway, so I went out to Michigan, and can I tell you a Toro-related story to going out to Michigan?
Sure.
So I was in Dr. Zelliger's office very frequently because I was the class president, and he and I hit it off just immediately. He was very fatherly. And he's very take you under the wing kind of person, and it was difficult. And I was in there all the time, but he was a pediatric orthopedic surgeon, or was it just orthopedic surgeon? And his friend and residency mate Harris Mainster is huge in Michigan. He was one of the original owners of Kmart, and he was the chief of surgery at Botsford Hospital that has a training program in surgery, which is what I thought I wanted to do. And so that was my first landing.
Okay.
When I went out there, and I guess Dr. Zelliger had called and told Dr. Mainster that I was coming. And so I remember very distinctly sitting in the doctor's lounge with my intern that I was assigned to and the upper level residents that I didn't dare to talk to. And we're sitting there eating, and this tall gentleman comes up from behind the senior that's sitting there and reaches over the table and says, "Are you Jennifer?" And I said, "Yes, sir." And I stood up, and he said, "You're one of Bernie's kids, right?" And I said, "Yes," and I shook his hand. And he said, "It's nice to meet you, Harris Mainster. If I can do anything for you, you let me know." And then he turned around and walked away. And the look on the faces of the residents that were sitting across from me, oh, I wish I had a camera at the time, but I remember very distinctly. And the senior was so mad because he's like, "I've been here for 6 years, and that man has no idea what my first name is." So I just was very quiet after that and tried to stay away from that resident so he wouldn't be mad at me. But that was so funny.
Not the first time I've heard it's a small community,
and
you never know
small.
who you may know somebody who knows somebody, and ultimately that opens the door for you.
Yes, so true, so true. So, and then I left residency in Michigan, and after 4 years in Michigan, I drew a line across the center of the United States and said, I'm never living north of this line again.
Okay.
And because it's just too cold, so I took my first job in North Carolina.
So you're talking about how you drew a line across the
Drew a
map
line.
and you weren't going to live
Drew a
north of
line.
that again.
I'm never
and then
living
went to
north of this again.
Carolina.
Please God, no. No more winter. I couldn't stand it. Well, I remember coming home at 2 o'clock in the morning from a shift in the emergency department and not being able to feel my hands. And so not being able to get the lock open. And so, the longer you stay out there, the colder your hands get. So that was just I went in the house and was just like, no, I'm just not going to do this ever again. So I got really good training in Michigan, but it wasn't for me. The weather wasn't for me. So then I moved to North Carolina. My first job was at a huge trauma center. I saw so many things in the first month of that job that I was told in residency, you'll never see this. And I think that the difference is the demographic of people. I moved from Michigan, where everybody has great health insurance provided by these big automakers, and they have great insurance and they have a great health system in Michigan. And then I moved to North Carolina, where there's like one major trauma center, which is where I went, and it's surrounded by the 6 poorest counties in the state, and they all, we were 100,000 visit a year ED. It was just insane. And so I learned so much, and I met my husband, and we got married and had a baby and said, it's time to go. So we searched, and California was on the list. But we had one remaining grandparent, and she was still on the East Coast. Okay. And so we chose Virginia. And it was a job that my husband didn't take. Instead, he took North Carolina. So we went back to Virginia. We interviewed in a couple different places, Fredericksburg, Roanoke, and the beach, and we just both called to the beach. So we have lived there ever since. We moved at the end of 2011, early 2012, and we have been there ever since. I work at Riverside Health in Virginia, which is a 4-hospital system on the, I guess here it would be considered the North Bay, but we call it the Peninsula. That's the difference between the East Coast and the West Coast. And so I cross the Hampton Roads Bridge Tunnel every day to go to work, and it's great. I like it. So, and I recently, very recently, as in the beginning of this month, relinquished my crown as the full-time nocturnist in our trauma center.
Okay, I didn't know that you
Yeah, I said 10 years is enough. I am done now. And I don't have to. Like it served a really good purpose when I had a baby and a husband who was still working, and then of course COVID came and changed a lot, and so my husband wasn't working, and it's just taken me a couple years to realize I didn't need to do it anymore. So, and I stayed probably as long as I did for my staff. Like I love my nurses. There's a very team approach to being on night shift that you don't get on any other shift, because we're it and we just rely on each other. And so I've been thinking about it for a year or so, and I had put it off for another 6 months and then said it's time to be done. Okay. So now I'm done with the nocturnist, but I still work there. Oh. I still work there. I'm probably going to retire from Riverside if I ever retire. That's great. I'll probably still be there.
So you mentioned COVID.
I did.
And that's our next question.
Is it?
Yeah.
The COVID.
What was it like? You were an ER doc during COVID.
At night.
I mean, we all saw the news. We were all watching the news and listening to Dr. Fauci tell us that
I have Dr. Fauci fan club socks.
We have to do all of this stuff, and
it seems nuts, doesn't it?
Yeah, but my take on it was always, and maybe I'm misremembering, but my recollection of that was, we're doing this so that our hospitals don't just get completely overwhelmed.
Correct.
Until we can get vaccines in place and get enough people vaccinated.
Right. This is the temporizing measure.
Yeah.
Right.
And so we have to do all of this inconvenient stuff, not so you won't get COVID specifically, but so you have a less of a chance of getting it, but specifically so our hospitals don't just get crushed.
Right.
Am I remembering that correctly?
You are remembering that correctly. That is all that was about.
Yeah,
yes. Not does it exist or doesn't it exist or any of the other long-standing conspiracy theories. It was to keep people from dying. It was to prevent unnecessary death, and that's really what that amounts to, because it's not just the people coming in who had COVID and who were dying from COVID or who were having complications from COVID. It's the person who is having a heart attack that we don't have enough equipment to protect the staff, or to protect the staff in order to facilitate doing the cardiac intervention that the person having a heart attack needs. So you weren't just stressing out the people, like the burden on the hospital is not singularly the COVID patient. The burden on the hospital is all of the COVID patients taking up the space when there's still the same level of acuity in your community. There's still heart attacks, there's still strokes, there's still appendicitis, there's still all of these entities, accidents, trauma, for crying out loud. I mean, it was nice that there was no one on the roads because the traumas were fairly few and far between. But once they opened that floodgate again, it was just like whoosh. And so I remember nights where I would sit with my my partner in crime is Cam Thurman, and he is also, he's part-time, but he does all nights. And we would sit there like kind of waiting for the other shoe to drop because of what we saw on television in New York and in New Jersey. And it was really, it was nail-biting because you just didn't know, were you ever going to get crushed? And there were some nights when we saw 4 people all night long because people were afraid of us. They were afraid. And I remember I had 2 little old ladies with abdominal pain. Both of them had bowel obstructions. Both of them had waited at home for 2 or 3 days before they even dared to come in because they were afraid. And they, you know, you're talking to them and you're building your rapport with them, and they go to instinctively touch your hand. And they would instead hover and look at their hand and your hand and take their hand back. And so we were heroes, but we were also pariah. We play the Remember When game with my nurses that are, you know, that are still there. And it's, remember when we had to wear hazmat suits in every room? Remember when we were wearing the hoods with the respirator? Or remember when we were hosing the hoods down with bleach and they were drip drying? And remember when we had to come to work in our own clothes, change into hospital scrubs, and then to go home, take the hospital scrubs off, shower, and put our own clothes back on before we went and got in our car and went home.
Is that to preserve the scrubs?
No. So that you didn't carry it home.
Gotcha.
So you didn't carry any of it home. And so, and then there was the masks. So my health system did a particularly good job at finding a way to preserve the masks that we had and then acquiring the ones that we needed. Did a great job at supply management. And so I feel fortunate in that regard because I know that my previous employer was not there because I'm still in touch with people. So depending on how well prepared your health system or practice is, it was harder or easier to stumble through all the restrictions and the needs for patients. And I remember that we had 2 or 3 masks with our name on it, and they went into a paper bag, and they went into like the cleaning room. And then I discovered that when they bring the little flashy lamp around, the decon lamp, so there's this device that you wheel in, has a little dome on the top, and it looks like a little planetarium going on in there, and I called it the disco light. They would bring the disco light in, but it's an antibacterial, antiviral light.
Okay.
And they would beam the room, essentially. And so, and the light went, you know, it was supposed to have a 360, whatever, all the surfaces that were in there. And so when we didn't have a lot of patients, I would tell the nurses that we'll put on like the regular surgical mask, and we're all going to put our masks on this tray, and we're going to slide it into that room while that light is going, and then our masks are clean again. And we would do that. They would come down, you know, several times a night to decon a room, and we would, like, as many of us as could, would like roll our masks into the room so that they could be clean, and then we would put them back on. So, and we talked about how, so when you go into a room with someone with COVID or a respiratory illness that will infect people by the particles, we have rooms where it's a negative pressure room where all the air coming in is sucked out. So we only have 4 or 5 of those, and but even then, we had 15 minutes before the air in those rooms is considered clean. Our trauma bay is 30 minutes. All the other rooms are at least an hour, and they're not negative pressure. So when the first time that we realized that it was no longer safe, we had a morning period where there was 4 hours where one or the other overlapping doc was there alone for 2 hours. And the day that we realized that that was not a safe thing to do was the day when one of my colleagues came in behind me, and right as she gets there, they call a respiratory distress, and they put it in one of the negative pressure rooms, and she goes in and she sees them and she assesses them, and then as soon as she comes out of the room, they wheel somebody else into one of the non-reverse rooms, and that's also a respiratory distress. And so then she goes in and sees that one, and while I'm just trying to wrap up everything else, she goes in and she sees that one, and then and she comes back out and she says, "Jen, I got to intubate bed 30. Can you hang?" And I said, "Sure." And so she goes in the room, and no sooner does she close the door behind her, which means 15 minutes, she's got to stay in there. And she's like, oh, I'm sorry. And she came out, she's like, "I got to intubate bed 30, and I think I'm going to have to intubate 36, but I'm putting him on BiPAP, and can you wait?" Yes, absolutely. As soon as she goes in that room and closes the door and can't come out for 15 minutes, they called a sepsis alert of this guy who's like actively trying to die, going into another room. And I'm like, well, I guess I'm staying for a while. So I had to go in there, and when I came back out and that all got sorted out, and she ended up going from that room to that room and getting stuck in that room, and our director came in, and who, by the way, got Physician of the Year for his leadership during COVID, and rightfully so, Dr. Gary Cavett, who has recently retired. But he came in and he saw me sitting there, and he looks at his watch and he's like, "What happened?" And I told him, and I said, "Gary, we can't do this anymore. There needs to be 2 of us here all the time, and this is why." And it was changed. The entire schedule was changed inside of like 3 days. Super responsive. It really takes it. I don't want to say it takes a village. That's wrong. But it takes everybody being on the same page to make that work. But we started to avoid that whole thing. We started intubating people outside. So as the night physician, I remember very distinctly in February, outside in the dark with a lighted fiber optic scope, intubating people on the ramp. It's freezing. The nurses are out there. EMS had been asked to get a line, so it was a group effort. EMS gets the line. The nurses are pulling the drugs. The respiratory tech is like right there with the bag, ready to take it as soon as I can intubate them, because as soon as you close off the airway, the danger of infection to those around is significantly reduced. Like, we feel comfortable wheeling them into the hallway and then into a room and then closing the door, and then nobody's stuck in a room for 30 minutes because you did the dangerous thing outside. But yeah, intubating outside in the dark, in February, underneath the big drive-up awning for the EMS. Yeah, and the sprinkler mister things to clean the mass, and just the disco light. I'd forgotten about the disco light until just now. There's just a crazy number of things that we did, and just never really knowing when this was going to end and how it's going to affect your community. We had food all the time. 24/7 people were bringing us food to thank us.
That's the hero part.
I guess so. Yeah, we ate well.
The banging of the pots in New York.
Oh yeah,
other major cities, not just New York.
I used to watch that. That's super touching. It makes you realize what all your efforts that you go through at school. It makes it like the realization that this is going to make a difference in the world. Yeah.
But it's not. I mean, is the pandemic over?
No.
Is it endemic yet?
No, so I just read something that said it's going to be.
We just lost someone in our Rotary family here. Just Wednesday.
From complications from COVID.
That's the
It's not over. It's endemic. But what's I think been downplayed, and this is stuff that we're just going to find out going forward, is that it's going to be a summer and a winter surge kind of thing. But the problem is that. I don't feel like anybody's talking anymore, and maybe I've just been on vacation. Nobody's really talking anymore about the deadly consequences of getting COVID. There was a study that came out of Italy fairly early on that said that your risk of getting a coagulation disorder, a blood clotting disorder, within the first 45 days after your exposure to COVID and contracting COVID goes up like 241%. And clotting leads to stroke. It leads to arterial occlusion anywhere in the body. It can be in your heart, which will give you a heart attack, be in your brain, which will give you a stroke, and it will kill your kidneys. I mean, anywhere a clot can land. And so I have not, in my career, which is now 22 years of clinical practice, I have not seen this much stroke, this much heart attack, and this many pulmonary embolisms. And the pulmonary embolisms they're massive. It's not a little thing. And the strokes are in really young people. And I just think that this is going to be one of those diseases that we're going to see in the book that is anatomical variants, like things that look normal but are caused by disease. Like there's latent TB, a chest x-ray for that. You can see that's a non-infectious TB patient they had it a long time ago, and this is what the scarring of their lungs looks like now. That's what COVID's going to have. COVID's going to have, this is, and it'll be pathology textbooks. It'll be radiology textbooks, especially the lungs, the scarring in the lungs. And, this is an example of massive pulmonary embolism caused by, it's just, there's going to be so much more to learn, and I don't think we know how much longer it's going to go forward. I don't mean to scare anybody. It's just like any other evolving disease.
Right.
The flu was devastating in 1918.
Right.
And it's endemic now. We have all these different strains, and we have vaccinations, and we move forward.
But we're also 100 years out from it.
We're also 100 years out. Yeah, so 100 years out from COVID, the medical community will have a better handle on what COVID's really done to our population. But it's going to be a while.
So share with us a patient care situation that, just from your everyday practice, that left a strong impression on you. What was it? Why is it so touching or memorable for you as you look back on it?
I have a very recent one. I think I told you a little bit about last night, and then I have an old one. The old one is this little boy who came in, whose brother had a nut allergy, and they were not aware that my patient had a nut allergy. And he went to a baseball game with his uncle, and his uncle gave him a bag of pistachios, and he was very allergic to pistachios, as it turns out. And so he came in with the swelling and heart rate way up and hypoxic, and looked really bad, and they had put him in a room that didn't really have all of the equipment. And so I went to assess him, and I'm like, I need him in one of the big rooms. And so the nurse that was back there wasn't used to critical patients, and so she's trying to move the bed and push it out of the room, and my charge nurse Charmaine just picks the kid up and runs around the corner and puts him in the room. And then we had to give him multiple doses of epinephrine to stop the allergic reaction, and and he's getting them in his legs over and over again. And then I realized who he is. He is the son of a prominent lawyer, possibly a district attorney. It's his son. And nobody wants to screw up when the district attorney's son, or any other family member for that matter, nobody wants to screw up, period.
Right.
But really the idea that there's a possibility of being sued at any point is makes a situation that's life-threatening much scarier for you as the physician to clear your mind so that you can handle the situation. And I realized who he was. And his dad came to the hospital. His mother came to the hospital, and I didn't meet his dad. And so he went lights and sirens to the children's hospital. And the physician at the children's hospital told the father that I had saved his son's life. And so the father and my patient came back a year to the day for the next 2 or 3 years to say thank you. So that's a memorable one for me.
Yeah.
And then the one that's more recent, speaking of blood clots and PEs and COVID, was a woman 4 years younger than me who came in looking really bad. And we've now had enough of them where I just look at them and I'm like, they have a PE. Like, I can't explain how distressed they look. They're so close to death. And they're looking at you and they're starving for oxygen, and they really need you to fix what's happening and to recognize what's going on and then try to fix it. And she was so sick, and she had the same thing happen, something happened a month earlier. And so I could read her chart from before, and she had to have surgery, and she had a very complicated case, and she had just gone home like a week earlier, and she stepped out of the shower and became acutely short of breath and then collapsed. And so she came in very distressed, and her husband was with her, gave some history. The EMS gave a great history, and we could see her. I love that most of my region is on the same electronic medical records, because when the patient can't talk to you, the record can. And so she told me, and the medics gave me the report, and I got up close to her, and gosh, the look on her face. And I said, "You had a blood clot in your lungs a month ago when you went to VCU. Do you feel the same right now that you felt then?" And she said yes. And so we got IVs, and we moved her into the trauma bay, and we where all the equipment is, and because they put her all the way at the end, and we wheel her like we're running her down the hall, and we put her in the trauma bay so we don't have to run the equipment. And so we get her in there, and we start we give her fluids, and we get her blood, and we start we do the bedside testing, and she's acidotic. And so I look at her, and I said, "You're losing control of your ability to breathe. Do you want me to intubate you?" And she said, "I don't know." And I said, "I only do it if you really need it." And she said, "Okay." And she'd been on and on her breather. I said, "I'm going to do one more test and see if this is improving. And if it's not improving, then that's what I'm going to have to do." And she said, "Okay." And so we did the second ABG, and she was going the completely wrong direction. So I had to intubate her. And we called Life Flight, because she was their patient. She was VCU's patient. And so we had called Life Flight very early on. And I think before I intubated her, and had talked to them, and gotten the ball rolling, because the sooner you let somebody know that somebody needs to come to them, the better off it is for the patient. And so we intubated her, and the medics for the Life Flight rolled in the door. Her heart rate went from the 140 that it used to be to 65, and her O2 sat went from the low 80s that we were holding at to 60, and then to 40. And I was like, somebody's got to check a pulse. And that's how it started. And I did not leave her bedside. Thankfully, she came in like an hour and 10 minutes before my relief came in, because the rest of my patients didn't get any attention. And I was done at 11, and I watched her roll onto the helicopter at 10 minutes to 2, because we spent 2.5 hours, 3 hours resuscitating her. CPR, epi, I pushed lytics on her, the clot busting drug, and then we get her back for a little while, and then I had to put her on several drips to keep her pressure up, and didn't really know how it was going to go, but had a good inkling, because we had to turn off her sedation and move her. She finally was stable enough to go. We turned off her sedation for long enough to move her from the bed onto the transport stretcher, and she started wiggling her toes on her own, and while she was on their stretcher. And I was like, "Guys, I think her sedation is off." And they're like, "Yeah, we had to turn it off to move her." And so they turned it back on, and she was answering questions for the staff at VCU when they rolled her through the door. She was able to answer questions. And I looked up in her chart the next day. I saw the medic that took her. The day before I left to come here, I saw him. He brought in another patient, and I asked him how she did, and he's like, "Oh, I think she's still alive," because she was answering questions when we rolled her through the door, which was not something that I knew. But I looked up in her chart, and they took her to surgery, to interventional radiology, and they extracted the clot. They sucked it out of her lungs, because the lytics that I had given her had broken it up enough that she could oxygenate, enough that it kept her alive. And the medicines also helped keep her blood pressure up, because her heart was working so hard. And then they went in, the interventional radiologist went in and sucked out all the clot, and then did another scan, and she didn't have any residual clot. So she was still alive on the day before I left. She was still alive, 7 o'clock in the evening.
Wow. I'm not sure how to follow up.
I don't know. Sometimes I have to take a deep breath. And I was so happy to read that I ran to, so part of coming off a night shift was having all of a sudden all these resources I'm not used to having. So I had a pharmacist in the room with me. And I went to her, and I was like, and I looked at her, and she knew exactly when she saw my face who I was talking about. I'm like, "She's still alive." And she's like, "She is not." And I'm like, "No, she is. She's still alive." And she's like, "Ah." there was lots of hugging. There's lots of, it's a team. I told you it's a team, and it takes everybody. You need everybody. It just was, it was so, like, Heather, my tech Heather said, my heart just lifted just a little bit. Just from knowing that what we had done had saved her. So,
wow.
Yeah, it's a worthwhile endeavor for sure.
Okay, this is a hard shift here.
This is a hard
this
shift
is a hard
here.
shift here after that.
I'm sorry. Am I traumatizing you? There's a level of PTSD with these difficult cases that
sure.
they don't, like, when you're like this for hours, it stays with you. And so, part of getting through it and having the ability to, like, the coping mechanism is that you talk about it with the other people that you experience it with. Yeah, so we do that. That's why they're my team.
So the hard shift is to bring it back to Turo.
Okay.
You're president of the Alumni Association
I
Board
am.
of Directors. Thank
I
you
am.
for that.
Oh,
It's been a wonderful first year and change.
Yeah.
A lot of stuff has been accomplished.
We're trying.
Why was it important for you to, when the call came out, would you be willing to do this? You said yes, and then when you and your new team got together and when the call was put out, who wants to lead the charge?
Wow.
So, what was your thinking? Why?
The
You've
same.
been gone a long time from
I
Turo,
have.
and now you're like all in.
I didn't know there was an alumni association. Honestly, I think that I had received one or two previous things from the university, probably something from your predecessor, like way pre-COVID. And then, depending kind of on where you are in your career, you either do or do not have time or interest to do these things.
That's true.
You think that you're busy now in medical school, but you get out and life just like takes over, and it just does. And so they contacted me a while ago. And so I had looked into it. And then when it was brought home for me, when I feel like I finally was like, I really need to see what Turo was doing, was when I was at work and one of my scribes sitting behind me. All of our scribes they're medical gunners that are trying to get a PA program or an NP program, or they want to go to med school. And Samantha was sitting behind me, and I knew it was that time because all the other scribes have been talking about where they had applied, and they're sitting next to each other. You hear the little conversation behind you, and Samantha had said where she was applying, and I didn't hear a couple of them. And so I said, I turned around and I started talking to her, and I said, where did you apply? And she told me, and I said, did you not think about applying to Turo? And she starts laughing, and I was like, and she's like, oh, no, Turo would never let me in. It's so hard to get into. And I mean, just like, what did you say? And because I had walked across the stage and departed from, not the newest, because Kentucky opened 2 years after we did. And so we were now no longer the least respected, newest college of osteopathic medicine in the country. And so we were very happy when Kentucky opened. But I had walked across the stage from a university that had 4 buildings, in a decommissioned submarine base. And for her to say to me that it's too hard to get into meant that everything that we had done in going out into the world and just being successful, like that's all you had to do to give your university a name for itself, is just go out and use what they taught you and make a life and help make a name for yourself. And in doing so, you will encourage the success of the university. And I was just really like, it's too hard to get into. So I Googled, in the time frame that I had at work, I Googled, and I was like, they have how many campuses now? Like, I remember there was talk about putting one in Vegas, because most of our rotations were in Vegas, and that made complete sense to me. But wow, they're like everywhere now. Yeah. And so when we were in San Francisco and they came in during orientation week, they asked for volunteers to be a representative of your class until we could have elections. And I was just like, I'll do it. And I'll do it. I'm in. This is my thing. This is what I'm doing. I might as well go all in and have a chance to mold and stuff. And so We all, we all had to build, and we started all the clubs. We, as many of the clubs as we could get started, SOMA, and it was, so when you called and asked for the Alumni Association, it was just the logical choice for me, because if anybody knows building from the ground up, it would be someone from my class. And you probably could have asked any of us if there wasn't anybody else in the list from my particular year, and so you probably would have gotten both hands from, if there were 2,000 tours in there, you probably would have gotten both hands to say, yeah, I'll do it.
Sure, yeah.
I'll do it.
Because you've done it before.
Because I've done it before, and honestly, and now I'm in a place. I told you I've been thinking about leaving night shift for a year or so, and finally decided that I'm still going to see my staff, and so it's not going to be a horrible transition, and it will make my life at home easier, and maybe I can do some other things, because I have enjoyed so much working with the residents in our program. And I do like their mass casualty incident drills and stuff. I run those. And so I've enjoyed that, but I'm not an academician. I don't feel like I'm that person that can quote studies. And I feel like to be an academician, you need to be able to quote studies, and I cannot. So I just, I kind of wanted to get involved on my own terms. And this is fun. This is fun, coming back and seeing people and going to a gala and meeting the students who are super excited. They're very excited. Very excited young professional people.
They got in.
They got in.
And one of the things that, Patty Salkin is, way up. She's like I probably should know this title off the top of my head. I apologize, Dr. Salkin.
You have a very high title, Dr. Salkin.
She's like the chief academic officer for like everything.
For everything.
Yeah. I came in from New York. She was here for the gala. She's a wonderful woman. And just really believes in the program. But one of the things, the reason why I go there is she was here for our orientation, and one of the things she told the students is, you belong here.
Yeah.
They're already successful. They're all coming here for their master's program or their doctoral programs. They've already succeeded academically.
Yeah,
this is just the next step, and she made it crystal clear, she made it crystal clear to them from the stage that you belong here. If you ever think that you don't, you earned your seat here.
Come sit in my office for a minute and we'll have a chat.
So why don't you share with us the importance, why is it so important to have women serving in medical professions?
Well, there's many reasons to have diversity in your providers in medicine, like they were talking about at the gala last night. I mean, it's imperative that you have someone who's going to provide health care to someone who, like, that they can get each other, that they have some, you got to find a common ground. Your bedside manner needs to help endorse trust between the two of you. And, if nobody in the medical field looks like you, there's just there's an underlevel of trust. We get asked all the time on a day-to-day basis, I want a female provider in the emergency department, and it's usually because they have a gynecological or OB complaint. And who is going to be better able to explain what this is supposed to feel like? What can I expect than another woman or another man who own the same equipment that you have a question about? There are some organs that are the same, but fundamentally, the hormones that we have as a male or a female very much determine many other. They greatly influence the other organ systems in your body, and so you really need to have that connection with the patients back and forth. We have a lot of refugees from the Middle East in our area, and some of them basically require that they cannot show themselves to anyone other than their husband or another female. And so, there's religious, there's social, there's lots of different reasons to have different people wearing the white coat, which I don't wear anymore, by the way. I do not.
Well, you're the doc.
I am.
Even on TV, you see doctors, they're in their scrubs or something like that. And
that's what I wear men's pajamas to work. Which is why I wore nicer clothes for today, because I wear pajamas every day. Every day, pajamas.
So what advice would you offer to medical students as they prepare not only to go off on rotations, but also beyond that residencies, and then to start
your life?
Be young doctors out in the field.
I'm glad that you had given me these questions ahead of time, because it gave me time to think about this. And two things. one, find someone that you admire, and try to emulate their energy. You don't have to be who they are or talk like they are, but find someone. I'm a fairly positive, upbeat person, and so I gravitate towards people who are, the same. And so find someone who emulates the kind of physician or the kind of provider that you would like to be, and then strive. Don't beat yourself up if you don't make it exactly perfect on the first try, but just strive and emulate, and then find a mentor who gets you. I was assigned in residency to someone that I had nothing in common with, and we met twice and did not click. And then I was later in residency, so I struggled for a little while because I didn't have a mentor, and our program was traditionally male, and I was in my class was the second class that had females in it, and so that's how far back I go. And so they finally assigned me to a specific physician for a month, and we clicked, and he encouraged, and he recommended, and he just kind of pointed in that direction and went like this, and that is all it really took for me to get it and to try harder and to keep working. So find someone you admire and emulate in whatever way you can. Find someone who gets you and let them encourage you and figure out how to lift you up and make you a success. And then the last thing is for self-preservation. Do something every day that you like to do. I like a cup of tea. It's the thing I like to drink. Some people like their coffee. I know people who can't get started in life without their coffee, but find something that's every day that's you, even if it's just sitting for a minute in the car before you get out and go into the class, and take a deep breath and just let it go. And a cleansing breath is a lot. It's really helpful. And just don't speak poorly of yourself to yourself in your head.
Right.
Talk nice.
Right.
Talk nice in your head.
Be your own best friend.
So be your own best friend, but don't talk about yourself in a negative way to yourself. Not now. Now you cannot do that. You have earned the right to be here. You are smart enough and you are capable enough, and so you really should not diminish your ability in your own head.
That's great advice.
Yeah.
And I think we're at our time.
Are we?
We are.
Again?
We are. Well, we're at our time.
Oh, we're time.
Yeah, we're at our time.
Time. Okay.
So, Dr. Himmel, thank you
Yeah.
again for joining us
Thanks
for
for
the
having
podcast.
me. Yeah. Thanks, everybody.
To everyone out there in the world, thanks for joining us. And until next time, take care, everyone.
Bye.